Huntington disease is a chronic, progressive, inherited disorder of the nervous system that affects both movement and cognition. It leads to a combination of involuntary movements, personality changes, and cognitive decline. And it does so over many years, often starting subtly. The disease typically appears between ages 35 and 45, though it can begin earlier, even in childhood. It affects people of all backgrounds and genders equally. Genetically, it's inherited in an autosomal dominant pattern, meaning each child of an affected parent has a 50% chance of developing the disease. The culprit is a mutation in the HTT gene, specifically a CAG repeat expansion. The more repeats present, the earlier and more severe the onset tends to be. This abnormal expansion produces toxic proteins that gradually destroy neurons, particularly in the striatum of the brain. In terms of pathophysiology, the striatum, including the caudate and putamen, is where the earliest and most severe neuronal damage occurs. This area plays a critical role in movement control. As the disease advances, damage also occurs in the cerebral cortex, affecting thinking, memory, and judgment. Eventually, even the cerebellum may be affected, further impairing coordination. Clinically, Huntington disease presents with a classic triad: motor dysfunction, cognitive decline, and behavioral disturbances. The most striking early sign is chorea, those involuntary, rapid, jerky movements that seem purposeless. At first, they may appear only during stress or anxiety, but over time they become constant, even during sleep. Cognitive decline starts subtly, with trouble concentrating, organizing thoughts, or reading emotional cues. Eventually, it leads to dementia. On the behavioral side, patients may exhibit irritability, apathy, impulsivity, depression, or even psychosis. Suicidal ideation is common, especially in the early stages, when insight is still intact. As the disease progresses, movements become more writhing and sustained. Speech becomes slurred, swallowing is impaired, and the risk of aspiration becomes a constant concern. Despite eating frequently, many patients become severely underweight due to the energy expended from constant movement. Over time, mobility is lost, and most patients will require a wheelchair, then eventually become bedridden. Diagnosis involves a combination of clinical signs, family history, and genetic testing. The definitive test is a DNA analysis confirming expanded CAG repeats on the HTT gene. MRI or CT may show atrophy in the caudate or putamen, often even before symptoms begin, but imaging is not necessary to confirm the diagnosis. There's currently no cure. Treatment focuses on symptom relief and preserving quality of life for as long as possible. For movement symptoms, tetrabenazine is FDA approved to manage chorea, but it carries a risk of depression. Other medications like benzodiazepines or antipsychotics may help, but overmedication can cause akathisia, which may be mistaken for worsening chorea. In more rigid or akinetic forms of Huntington disease, levodopa may offer short-term benefit. Psychiatric symptoms are often managed with SSRIs, tricyclic antidepressants, or antipsychotics, depending on the nature and severity of symptoms. Psychotherapy can help address depression, anxiety, or behavioral challenges, especially early in the disease, when insight is still present. Nursing care requires close attention to both physical and emotional safety. Patients are at high risk of injury due to involuntary movements, so padding the environment is important. Headboards, bed rails, and sharp corners should be addressed. Heel and elbow protectors may help reduce skin breakdown. Safe ambulation should be encouraged while still feasible, using mobility aids as needed. If restraints are ever used, they must be padded and carefully monitored. Nutrition is another major concern. Because chorea burns so many calories, patients often need high-calorie, nutrient-dense meals. Thickened liquids and pureed foods may reduce the risk of aspiration. Verbal coaching and hand-over-hand assistance can help support self-feeding, and caregivers should be trained to distinguish between voluntary refusal and involuntary movements that mimic refusal. Communication eventually becomes a major barrier. Introducing communication aids early, like picture boards or gesture systems, can preserve autonomy. Eye contact, simple phrases, and patient engagement are essential. Even if speech is lost, understanding often remains. Cognitive and emotional support is just as important. Orientation tools like clocks, calendars, and visual cues can help. Social inclusion matters deeply. Patients should never be treated as if they've already disappeared. They are still living, and deserving of respect until the very end. As the disease advances, discussions about end-of-life preferences should be approached with compassion and honesty. The care team may need to help families navigate decisions around feeding tubes, respiratory support, and long-term care. Resources like the Huntington Disease Society of America can provide vital education and support. Most patients with Huntington disease will live 10 to 20 years after symptom onset. Death often results from complications such as infection, aspiration pneumonia, heart failure, or traumatic injury due to falls. Care is best delivered by a multidisciplinary team that includes nursing, neurology, physical and occupational therapy, speech pathology, psychiatry, and palliative care. Nurses play a vital role not only in direct care, but also in caregiver education, emotional support, and advocacy. The most important things to remember: protect the patient's safety, support their dignity, plan ahead for feeding and communication needs, and never underestimate the emotional toll on both the patient and their family. Huntington disease is devastating, but compassionate, skilled care can make a meaningful difference in how someone lives through it.